Hello everyone, I am Shahtaj and today we will be discussing a very important topic which is the gastroesophageal reflux disease. Now GERD develops whenever the esophageal mucosa is exposed to the gastroduodenal contents for a prolonged period of time. Now these contents would include the stomach acid, pepsin, bile as well as the pancreatic secretions. These contents have the ability to irritate the esophagus, as a result producing the symptoms. This means that GERD is going to develop whenever we have failure of normal anti-reflux mechanisms. Now let's understand the risk factors associated with the disease. This picture is taken from Davidson and it summarizes all the risk factors very well. However, we will be discussing each of them in detail. Let's first talk about abnormal lower esophageal sphincter with its reduced tone or inappropriate relaxation. This in fact is the most common risk factor. However, in order to understand the main pathophysiology behind this, let's first understand the lower esophageal sphincter and its physiology. So it's a physiological sphincter, which means that it is a high pressure zone. This pressure is somewhere between 10 to 30 millimeter of mercury. It lacks a muscular ring that makes up other sphincters of the body. For example, the pyloric sphincter. It transiently relaxes only to allow food to enter the stomach from the esophagus and remains tonically contracted other times to prevent reflux. Now let's discuss the components of the lower esophageal sphincter in a little bit more detail. These include the intrinsic smooth muscle of the distal esophagus that remains tonically contracted. We already discussed this. Then we have the intra-abdominal esophagus. The length is somewhere around 3 to 5 centimeter. Let's understand this. We know that the esophagus consists of three portions. We have the cervical region, then we have the thoracic region located in the mediastinum, and after it crosses the esophageal hiatus, before it opens into the stomach, this portion is the intra-abdominal esophagus. And this adds to the integrity of the lower esophageal sphincter. Then we have the right crux of the diaphragm that encircles the hiatus and compresses the esophagus during inspiration. Let's understand it through a picture. We can see here in the picture that the two crura of the diaphragm, the right and the left, they are pinching on the esophagus, and this is also going to compress the lower esophageal sphincter. Then we have the angle of His, which is an acute angle between the esophagus and the fundus of the stomach. We can see the angle of His here in the picture as well. This is the angle, and this angulation is also going to compress the lower esophagus. Then we have the phrenoesophageal ligament, which attaches the esophagus to the esophageal hiatus, maintaining the alignment of the gastroesophageal junction. And we can see the phrenoesophageal ligament here. All of these components are responsible for maintaining the integrity of this lower esophageal sphincter, which means that loss of any component leads to increased transient relaxation, predisposing to GERD. The next risk factor is defective esophageal clearance. In GERD, we have decreased peristalsis, and decreased peristalsis leads to decreased acid neutralization by the saliva and decreased clearance of acid. As the acid remains in contact with the esophagus for a greater amount of time, it leads to mucosal injury. A few risk factors associated to lifestyle includes obesity and dietary factors. Now, obesity is going to increase the intra-abdominal pressure, and we will be discussing intra-abdominal pressure in just a moment. However, dietary factors, that could be spicy food, minty, citrusy food, or fatty food, they relax the lower esophageal sphincter, and one more contributing factor is that they delay the gastric emptying. The next risk factor is hiatal hernia, especially the sliding type of hiatal hernia, where the gastroesophageal junction and the proximal stomach both are displaced proximally into the thoracic cavity. As we can see here, they are going to be displaced proximally upward, as a result of which we are going to have loss of intra-abdominal length of esophagus, and that leads to loss of diaphragmatic support to the esophagus. We can see here in the picture as well, we studied that the two crux of the diaphragm compresses the esophagus and then here that support is going to be lost. So especially in sliding type of hiatal hernia, we are going to see GERD. Up next, we have delayed gastric emptying. It is seen in conditions like diabetic gastroparesis and gastric outlet obstruction. Now, these conditions lead to food remaining in the stomach for a longer period of time, as a result of which we have increased gastric volume and increased gastric pressure. This pressure that builds up in the stomach is going to exert upward pressure on the lower esophageal sphincter, thus leading to GERD. The last risk factor that we'll be discussing is increased intra-abdominal pressure. It is seen in conditions like obesity and pregnancy, and these reduce the lower esophageal sphincter pressure. Now, it is important to note when this pressure decreases greater than 6 mm of mercury, it predisposes to GERD. Now, these were the risk factors for the gastroesophageal reflux disease. We have discussed each of them in detail, and now we will move forward to discussing the clinical features. It usually presents with a classical clinical triad of retrosternal burning pain and sensation, also known as heartburn, which in fact is the most common feature. Other than this, the triad includes epigastric pain that radiates through the back as well as regurgitation. All of these factors are going to be aggravated by taking fatty and spicy meals. Like we discussed, that these are going to delay gastric emptying. Other features of GERD include water rash. Now, water rash is when we have excess salivation due to reflex salivary gland stimulation by acid in the esophagus. Similarly, irritation of the pharynx and the larynx with the acid is going to result in pharyngitis and laryngitis. It can also produce chronic cough and asthma-like features like wheezing and hoarseness. It can also cause damage to the teeth, resulting in dental caries, recurrent chest infections, and atypical chest pain that can mimic angina due to reflux-induced esophageal spasm, again due to acid in the esophagus. It can result in nocturnal reflux, which is going to occur at night. Then we can have odonophagia with hot beverages, citrus, and alcohol. Now, odonophagia refers to painful swallowing, which means that the acid must have irritated the lining so much that it's now causing pain to the patient, and we can have dysphagia, which is difficulty swallowing. Now, a patient with GERD will not normally present with dysphagia, and if dysphagia is present, it is suggestive of a stricture. Now, what do we understand by the term stricture? A stricture is when we have narrowing of the lumen, and food is going to accumulate proximal to the stricture. If this is the esophageal lumen, if we have a narrowing or a stricture here, the food that you're intaking is going to accumulate proximal to the stricture, resulting in difficulty swallowing. It is actually a complication of GERD, and we will be discussing its pathophysiology in detail later. This means that when a patient presents with all of these symptoms, it means that the patient has a severe type of GERD. If a patient presents with any of the following features with GERD, the next step is that we assume the diagnosis of GERD, and we do not investigate at the first visit. In fact, we suggest the patient some lifestyle changes and start the patient on empirical treatment with proton pump inhibitors, which in fact are the first line drugs for GERD. Now, what are the few indications for investigations? Since we discussed that we will not be carrying out investigations at the first visit, we will perform investigations when the empiric treatment of proton pump inhibitors have failed, when the patient presents with atypical symptoms like dysphagia, or a complication is suspected, for example, strictures, or the patient has an increasing age which is greater than 50 years of age. Now, the first investigation we are going to talk about is endoscopy. Now, endoscopy is the first line investigation and also the investigation of choice. So, IOC, short for investigation of choice. In the endoscopy, during the early disease, we will have a normal looking esophagus. Now, this is also referred to as non-erosive reflux disease, which is seen in somewhere around 70% patients. However, in a late or a long-standing disease, we will have appearance of reflux esophagitis, peptic stricture, and Barrett's esophagus. All of these are actually complications related to GERD, and complications will be discussed at the end of that video, like I mentioned before. The next investigation of choice is going to be 24-hour pH monitoring. This is the gold standard for the diagnosis of GERD. And this can be combined with esophageal manometry. Esophageal manometry means checking the pressure of the lower esophageal sphincter. 24-hour monitoring, however, is going to be the gold standard. A pH probe is kept 5 cm proximal to the lower esophageal sphincter like it is mentioned in this picture. This 24-hour pH monitoring is not done in all the patients. In fact, we have a few indications which are as follows: that it is usually performed when the diagnosis remains unclear even after endoscopy. Surgical intervention is considered in the patient. A few prerequisites are that we need to stop the proton pump inhibitors 1 week before the test, and then the pH probe has to be kept 5 cm proximal to the gastroesophageal junction like we have discussed. The diagnosis of GERD will be made when the decimeter score is greater than 14.72 or when the pH is less than 4 for 4% of the time. Another investigation could be a CT scan, particularly performed for hiatal hernias. However, this is not routinely performed in GERD patients. The next thing we will be discussing is the management of GERD. The first thing that we suggest a patient before the start of pharmacological treatment is lifestyle changes. These include weight reduction, avoidance of fried, spicy, minty, and citrusy foods, small frequent meals, dinner should be 2 hours before sleeping, alcohol and smoking cessation, and elevation of bedhead in cases of nocturnal symptoms. The next thing we are going to discuss is the pharmacological therapy. These includes a variety of different drugs to treat GERD, which are as follows. PPI. This is in fact the most effective drug of them all, and this works by decreasing the gastric acid production. It relieves the symptoms and also heals the inflammation. It is usually given as a step-down approach, which means that we give a standard PPI dose for 8 weeks and then we gradually reduce the dose or we cease it. If no response occurs in patients, then we either increase the proton pump inhibitor dose or we add an H2 receptor antagonist. The examples of such drugs include omeprazole and esomeprazole. Then we have the H2 receptor antagonist, which also work by decreasing the gastric acid production. However, their mechanism is a little different, where they only relieve the symptoms of GERD and are not responsible for healing inflammation like we discussed in PPIs. The drug examples include famotidine and cimetidine. Then we have antacids. Antacids work by neutralizing the gastric acid. Examples include magnesium hydroxide, aluminum hydroxide, and calcium carbonate. Then we have prokinetics. They usually work by increasing the gastric motility. They're usually used for dysmotility features, and examples include domperidone and metoclopramide. Let's also discuss a few adverse effects associated with the pharmacological therapy. These include gastric changes, which includes parietal cell hyperplasia and hypertrophy, rebound acid hypersecretion after withdrawal, decreased iron, vitamin B12, and magnesium absorption, increased risk of salmonella, campylobacter, and C. difficile, gut microbiota changes, and an increased risk of H. pylori associated gastric mucosal folds, which means that an H. pylori eradication is going to be advised in every patient that requires proton pump inhibitor use for greater than 1 year. The next treatment option that we are going to discuss are endoscopic treatments. And these are of 5 types. Number 1, we have endoscopic suturing, which is placing a suture in the stomach below the cardia that is going to create folds that accentuates the angle of His. We have already discussed the angle of His in detail. However, accentuating the angle of His is going to strengthen the lower esophageal sphincter. We also have a picture. This might make it a little bit more easier. We can see it here that we are placing a suture endoscopically and we are creating folds, and these folds are actually physiologically strengthening the lower esophageal sphincter. The next endoscopic treatment is radiofrequency ablation of LAS, where we are doing controlled tissue injury, and this tissue injury is going to be followed by fibrosis and remodeling, and that decreases the transient relaxation of the lower esophageal sphincter. Then we have injections of submucosal polymers, where we inject bulking materials into the sphincter, the lower esophageal wall. However, this is not preferred because there is an increased risk of recurrence. Then we have 2 other methods which are not important, but just for the sake I've mentioned it, that we have a LINX device, which is magnetic sphincter augmentation, and we have transoral incisionless fundoplication. It's a NOTES procedure where we go to the desired area through a natural orifice in the body. In this case, the natural orifice is going to be the mouth, of course. and then it is going to be an incisionless fundoplication. However, these three are important to remember. Alright, continuing the management, the most definitive treatment for GERD is surgery. And before understanding the type of surgery that we do, let's first understand the indications for this surgery. These include patient not responding to medical therapy, patient developing complications like Barrett's, strictures, and cancer, GERD associated with large hiatal hernia, and a patient wanting to give up on medical management. So the surgery is known as fundoplication, and it refers to wrapping of the fundus of the stomach around the intra-abdominal portion of the esophagus, thus strengthening the lower esophageal sphincter and preventing reflux. Let's discuss the types of fundoplication. We have two major types of fundoplication, which is the total fundoplication, also known as the Nissen's fundoplication, and we have the partial fundoplication. Let's first understand total fundoplication through a picture in order to make it a little bit more easier. We can see here that the fundus of the stomach is completely wrapped around the esophagus and it is sutured anteriorly. This means that Nissen's fundoplication is a 360-degree fundoplication. Now let's discuss a few pointers related to Nissen's fundoplication. Since it wraps very tightly around the stomach, it in fact provides the most durable long-term control of reflux. Even though it provides the most durable control, it results in an overcompetent cardia, and this gives rise to the most common complication associated with Nissen's, which is known as the gas bloat syndrome, and this is the only reason why Nissen's is not recommended as a treatment of choice anymore. So let me color this in a different color to highlight it. Now let's understand what do we mean by gas bloat syndrome. It is the inability to belch or burp, as a result of which the stomach is going to fill with swallowed air. It can result in early satiety, where the person is going to feel full suddenly after having the meal, abdominal bloating as a result of swallowed air, and there is going to be increased passage of flatus. Now gas bloat syndrome can be avoided in two ways. We can either perform a partial fundoplication, or we can perform a floppy Nissen's. Floppy Nissen's means that we are going to loosely wrap the fundus around the esophagus, and as a result of which it is going to result in decreased tightness and decreased risk of gas bloat syndrome. Now this doesn't mean that we are not wrapping the fundus around fully. We are. It is still going to be a 360-degree wrap, but it is going to be floppy, which means we are going to loosely tie the fundus around the esophagus. Now let's talk about partial fundoplication, where only a part of esophagus is covered and then the rest of the esophagus is left uncovered. And it has a few advantages as to why this method is preferred over total fundoplication. It causes less obstruction, there's easier swallowing, which means there is a decreased risk of dysphagia. There is ability to belch, it means that the person can easily burp. And then there is a decreased risk of gas bloat syndrome, which we discussed was the most common complication in total fundoplication. Moving further, let's now discuss the two major types of partial fundoplication. We have anterior and posterior. We will be looking at a diagram, but first let's understand the definition. Anterior fundoplication means when the fundus of the stomach wraps around only in front anteriorly of the esophagus, and the posterior esophagus is going to remain uncovered. Now anterior fundoplication is of further two major types. We have Dow and then we have Watson. In Dow, the angle of wrapping is 180 to 200 degrees anterior, and in Watson it is 180 degree anterior. Let's understand anterior fundoplication through a picture. I have here a picture of doors, which shows that anteriorly the esophagus is covered, as we can see here, and posteriorly it remains empty. Alright, so regarding posterior fundoplication, the definition is going to be similar to anterior fundoplication. It is just that in posterior, the fundus wraps posteriorly and anterior esophagus remains uncovered. It is important to note that we also have a type of posterior fundoplication which is known as toupee, where the fundus wraps around at 270-degree angle posteriorly. We can see it here in the picture as well. that the stomach wraps around the back of the esophagus and anteriorly the esophagus remains empty. So posteriorly it is covered and anteriorly it remains uncovered. Before we proceed ahead, let's also discuss that fundoplication is not only done for GERD, in fact it is also done for cases of large hiatal hernia. And as we discussed that hiatal hernias are a predisposing factor to GERD, so there are a few principles of the surgery that we are planning to achieve, which is number 1, to restore the intra-abdominal length of the esophagus, because loss of the intra-abdominal length is one of the major factors that leads to GERD, and the minimum length should be 3 cm. We need to tighten the diaphragmatic crura around the esophagus to accentuate the lower esophageal sphincter even more. To wrap the fundus around the esophagus was actually the meaning of fundoplication. This is also known as a shoe shine maneuver. We have to preserve the vagus nerve and we have to reestablish the angle of His. Now let's discuss the approaches of fundoplication. It could be done via an open surgery or laparoscopic surgery. And laparoscopic is the preferred method. Let's also discuss the ports. So for laparoscopic fundoplication, we have 5 ports and they are placed in the following fashion. We have the umbilicus one, which is also the camera port. And then we have one below the xiphoid process. This is to retract the liver. Then in the epigastric region, only in the left midclavicular line, we have one port. And then again in the epigastric region, in the right midclavicular line, then one in the left anterior axillary line, lateral to the umbilical port. Let's also discuss the steps. As we discussed that it is a laparoscopic surgery with 5 ports, we are going to separate the cardia of the stomach and the lower esophagus from the hiatus. We are going to mobilize the esophagus in the mediastinum, and then we are also going to mobilize the fundus by dividing the short gastric vessels. And then in full fundoplication, the fundus is fully wrapped, and in partial fundoplication, we can have an anterior wrap and a posterior wrap. And in both of the following partial fundoplication, we leave a strip of esophagus exposed. Before we proceed to do the complications associated with GERD, there was another thing which was mentioned in Bailey's regarding the management. In cases of failure of fundoplication or persistence of symptoms. It's not that important, but I'd like for us to go in a little bit detail. That in cases of recurrent reflux due to either anatomical failure of original repair, or we have persistent dysphagia due to a tight wrap or a slippage of wrap or hiatal fibrosis, then a revision surgery is required. So in revision surgery, we do fundoplication only, right? So this is going to be known as a revision fundoplication. When the revision fundoplication is no longer feasible, or you have done it repeatedly and it continues to fail, then you have to do enterectomy with Rho and Y reconstruction. In enterectomy, the antrum of the stomach is going to be removed. That results in a decreased acid production. And by creating Rho and Y, we divert the bile and pancreatic secretions. That decreases the amount of refluxate, thus relieving GERD. So this is all we need to know about the management of GERD. Now let's move on to doing the complications associated with the disease. The first complication that we'll discuss is reflux esophagitis. It develops when the reflux of gastric acid into the esophagus results in mucosal injury, thus leading to activation of the inflammatory cascade. This results in long-standing chronic inflammation causing erosions and ulcerations. Erosion and ulcerations due to superficial mucosal breaks will result in pain and bleeding. And fibrosis and stricture occurs in healing with scar formation, whereas scar contraction narrows the lumen, leading to dysphagia. On endoscopy, reflux esophagitis is seen as redness, bleeding, ulceration and stricture formation. We can see here that we have redness, and then we can also see ulcer formation here. There's a complete bed of ulcer which will bleed. After discussing the clinical features and endoscopic findings of reflux esophagitis, let's also talk about the grading of reflux esophagitis, which is known as Los Angeles grading. Now, Los Angeles grading comprises of 4 grades: grade A, B, C and D. Now, grade A is when we have greater than 1 mucosal break, which is less than 5 mm in size and not extends between the folds. We can appreciate it here in the picture that we have 2 mucosal breaks that do not extend horizontally. Then we have grade B. It is exactly similar to grade A, where we have greater than 1 mucosal break. However, the size here is different. The break is increasing in size. It is greater than 5 mm, and again, it do not extend between the folds. So the length of the scar or the length of the mucosal break is increasing. But again, no horizontal connection between them. Then we have grade C, again greater than 1 mucosal break, but it is continuous between the folds, involving less than 75% of the circumference of the esophagus. This means that the folds are going to be horizontally connected, but less than 75% circumference of esophagus is going to be involved. And then grade D is going to be similar to grade C, where greater than 1 mucosal break. However, it is involving greater than 75% of the circumference of the esophagus. We can see it here that it is extending more in the horizontal manner as compared to C. So that's it. That's all we need to know about reflux esophagitis. We discussed about its clinical features, then we discussed about certain endoscopic findings, and then the grading as well, known as the Los Angeles grading. The next complication that we will be discussing is the stricture formation. Now, fibrous strictures develop due to long-standing esophagitis, as we discussed here, that healing of esophagitis with scar formation, and as the scar contracts, it narrows the lumen, leading to dysphagia. This is what we call as a stricture. It is more common in older people with poor esophageal peristaltic activity, which means that there is going to be decreased clearance of acid from the esophagus. The most important feature about stricture is going to be that it is important to distinguish benign reflux-induced stricture from a carcinoma. Now, why is this important? Because both stricture and carcinoma have similar clinical presentation, which are progressive dysphagia, first to solids, then to liquids, weight loss due to decreased food intake, and narrowing, which is seen on barium swallow or endoscopy. Now, luminal narrowing in both the conditions occur due to different reasons. We know that in stricture it is occurring due to fibrosis and scarring from esophagitis, and in carcinoma it occurs due to tumor growth that encroaches the lumen and causes narrowing. Let's make a quick diagram for it. That in stricture formation, the narrowing occurs due to contracture of scar, and it is going to lead to dysphagia. However, in carcinoma, there's going to be an outgrowth from the wall of the esophagus, and as it grows, it is going to narrow the lumen. Now, how do we distinguish it on endoscopy? So, on endoscopy, the benign stricture is going to be present above the gastroesophageal junction, and it is going to be short, somewhere around 1 to 2 centimeter. There's going to be smooth mucosal surface with symmetrical narrowing and no irregular mass, because an irregular mass is going to be seen in cancer. So this is going to be a benign stricture, and this is how we are going to differentiate it from a carcinoma. Let's also look at a picture of a stricture. This picture is taken from Bailey's, and the description is really good. That on the left side we can see active esophagitis. This is active inflammation going on, and on the left side we can see a stricture healed with columnar epithelium. So we have luminal narrowing here, and then this is going to be a stricture. Now, the diagnosis of this stricture is usually made via endoscopy, and when we take endoscopy, we also take multiple biopsies to exclude any malignancy, and then the treatment is long-term PPI, and then we can also perform endoscopic dilation. However, long-term PPI use is treatment of choice. The next complication that we are going to discuss is anemia. Now, anemia develops due to two major reasons. It develops due to occult blood loss from long-standing esophagitis, like we discussed here, that erosion and ulcerations causes pain. So reason number one is going to be occult blood loss. Now, occult meaning blood loss that is not visible to the human eye in cases of long-standing esophagitis. And the second cause, that if large hiatal hernias causes erosion in the neck of the sac, and these are known as Cameron ulcers. Now, we can see it here in the picture as well, that in cases of rolling esophageal hernia, we have longitudinal ulcers at the base of the herniation, and these are known as Cameron ulcers that bleed, causing anemia. The next complication we will be discussing is esophageal shortening. Now, esophageal shortening is of two types. We have apparent esophageal shortening and true esophageal shortening. Now, apparent esophageal shortening is when the esophagus appears to be smaller in length, however, it is not actually decreasing in size. It is seen in cases of large hiatal hernia where the gastroesophageal junction is displaced upwards, and we saw it. Let's just make a quick diagram that through the diaphragmatic hiatus, the esophagus is going to bulge upward along with the proximal stomach, right? And then when we mobilize the esophagus from the mediastinum, it can be brought back to its original position. Now, this is going to be the distinguishing feature of apparent from true esophagus. If you can recall, this was the principle of fundoplication, and in fundoplication we read that We also restore the intra-abdominal length of the esophagus. Whereas true esophageal shortening is seen in chronic reflux and inflammation. This means that true esophageal shortening is what we see in GERD. Now, this is a true complication of GERD. And we already discussed that with fibrosis of the esophageal wall, we are going to have contraction, and that causes esophageal shortening, and this is going to be true decrease in length. And with full mobilization, it cannot be brought back to its original position. Now let's discuss the treatment of esophageal shortening. For apparent esophageal shortening, the treatment was fundoplication. We already discussed its principle as well. However, for true esophageal shortening, which is seen in cases of GERD, the surgery is known as Colles-Nisen's operation. It comprises of two phases. Phase number 1, which is known as Colles gastroplasty. Now, Colles gastroplasty is when the upper part of the stomach is fashioned into a tube that acts as an extension of the esophagus, and this is going to be known as the new esophagus. This is followed by Nisen's fundoplication to control reflux. And we know in fundoplication, we are going to wrap the fundus around the esophagus. And since it is Nisen's fundoplication, this wrap is going to be a 360-degree wrap. These were all the complications that we will be discussing about GERD in this video. However, there is another complication of GERD, one of the most important ones, which is known as Barrett's esophagus. Now, Barrett's is a much lengthier topic, and it is going to be covered in the next video. So I'm going to write next video. This is all about the gastroesophageal reflux disease. Thank you so much for watching.